All right, well, I think we are going to go ahead and get started. Well, welcome everyone and good afternoon. Welcome to our August PLENTalk, Endemic and Global Health. My name is Nadia DeCastris and I am serving as the Summer Communications Intern here at PLEN. And I am a rising senior at Augustana College in Rock Island, Illinois, studying public health, psychology, and communication studies.
Hi, everyone. Welcome. We are so grateful to have all of you here today. My name is Paige Botcher, and I'm the current development intern here at PLEN. I am a graduate student at American University studying global governance, politics, and security. We are so excited to be hosting this PLEN talk on the global pandemic. So today, our moderator is Kirsten Axelson. Kirsten works with leaders in healthcare and builds diverse and effective teams, helping to develop business practices that lead to affordable medicines, positive public perception, and sustained investment in scientific advancement. She's also a founder and the executive secretary of the Preparedness and Treatment Equity Coalition, which is an organization that focuses on identifying metrics and reimbursement pathways to achieve greater equity in healthcare. And now I'm going to hand it back over to Nadia, who will introduce our speaker.
So thank you so much, Paige. We are excited to be here today with Dr. Emily Landon. So Dr. Emily Landon is the Chief Infectious Disease Epidemiologist at the University of Chicago Medicine, who specializes in infectious diseases and leads the academic health systems, infection control, and prevention efforts. So now I'm going to go ahead and turn it over to Kirsten and begin our presentation. So enjoy, everyone. Thank you.
Hi, Dr. Landon. So great to be with you here today.
Kirsten, I'm excited to be here with you guys and with PLEN. This is exciting.
Thank you. Thank you all so much for tuning in. So Dr. Landon, I just wanted to start off with asking you to kind of compare how you feel today to how you felt when you began your career as an infectious disease specialist. And did you anticipate that you would experience a pandemic in your lifetime, a global pandemic in your lifetime?
Well, I started working in this field in healthcare and hospital epidemiology and sort of outbreak management and infection prevention in hospitals back in like 2007, which was, a few years after I'd become a physician to begin with. And at that time, I was full of a lot of positive optimism, and I was sure that I was going to get everything to zero and we were going to have no more healthcare associated infections. And the one thing that really scared me about taking on this responsibility when I became the hospital epidemiologist at University of Chicago was a global respiratory virus pandemic. I'd already done, 2009 we had H1N1, but this was influenza. That was something that was known. In 2014, we managed Ebola, which was, also a better known disease, but a lot was learned during that time period. And during our Ebola outbreak and our Ebola response, I said all the time, don't worry, guys, it's not like this is a respiratory virus pandemic. It's gonna be fine. And I always said I would quit before we ever got to a respiratory virus pandemic, but I did not do that in time. So instead, I found myself, in the middle of one. And so, I knew that there was a possibility, in this job, you sit at these town halls and you go to these tabletop exercises and all sorts of things like that, where you practice what you're going to do in a respiratory virus pandemic, because it is kind of the worst possible option. And I have sat at that table and in those little rooms and said hundreds of times, and this is when we'd recommend closing schools, and this is when we'd have to do social distancing measures, and here's when we'd have to have healthcare workers, we'd have to cancel elective surgeries. It's a whole nother thing to find myself actually saying it, standing next to the governor of Illinois about the entire state, or in, to people at the hospital, we need to shut down all the clinics, we need to cancel all the surgeries. We're not gonna be able to do this. We don't have enough masks. We don't have enough PPE. So it was really different then. It feels very different. So yeah, didn't love that. But it is, you find everybody finds themselves sometimes in a place where this is the one challenging thing that they really hope they never had to do. And then you have to do it. And it can be personal, or it can be public, or it can be work related, but it's just part of life.
Well, talking about this pandemic being part of life, are we entering the end of it? Where are we now? Cases are high, but seem to be less severe. what's our outlook, and are we going to be living with this forever, or is this something that will eventually become not a part of our lives?
Well, we missed some opportunities to sort of make this something that we could get past completely from a public health standpoint. And so now we're in a situation where we're looking at an endemic picture. But I think it's really important to remember that a lot of people talk about endemicity as though we're saying end-emic. And it's not that. It's endemic. And that means among the people and in the people. And it means that the disease just lives with us and lives in our communities and causes disease all over the place, at sort of predictable or somewhat predictable intervals, may have little epidemics here, little outbreaks there, but it's just all the way around. You don't need somebody to bring it in order to cause, like monkeypox, you'd have somebody import the disease in order to cause it. But now this is just here, and we just have to have it with us all the time. And I think that there's a lot of people don't really understand exactly what that means. And I know that's going to be a big focus of what we're going to talk about today and how that's going to affect us. So I don't want to get too into the weeds on that and right this minute, except to say that we can't escape this now. And any concept, the sort of main talking point that I have here is that while the acute illness phase, where we're worried about what damage the acute illness is going to cause, is not the biggest threat to us right now. That doesn't mean that it won't be a threat later. It also is pretty clear that we don't really know what the long-term effects of this COVID is going to be, and who's at greatest risk for them, and what that risk is for, and how it's going to affect us long-term, and how that's going to affect our healthcare system, how we pay for our healthcare system, what it's going to do to our workforce, our economy, and what the effect of COVID is going to be is so much bigger than what we've even begun to think about yet. And yet it's already had such a huge impact that it can be really hard to understand or to conceptualize what it's going to do to us in the long term. And I think that's I think we should keep that in mind, that we're dealing with one of those iceberg situations where we've only seen the part above the water.
Well, you mentioned that you're an optimist, and you also mentioned that there were, we missed some opportunities to contain this early on. But what did we learn? What are some of the lessons we learned that we can plan for in future epidemics or even major flu outbreaks?
Yeah. I think that
viruses.
I think that the most important thing we learned is that we were too slow. We were too slow and we were too lethargic. And while we may have learned that, that doesn't mean that we've corrected it, because we're making some of the same mistakes with monkeypox. Although I want to be clear, monkeypox does not pose the same kind of threat that COVID does, at least not right now. And I don't expect it to need to pose that kind of threat. And what happened was we sort of lost, because respiratory viruses can spread so effectively, and because they spread from person to person, it can be really difficult to contain them. And we lost the opportunity to contain the virus back when we didn't test it, when we didn't have enough tests and we didn't test enough people. And the model that we followed in public health of sort of keeping all the information centralized through the CDC and them really keeping a handle on the information and the handle on the situation is how they have encapsulated previous problems, right? Centralizing everything to them. And by not recognizing that that wasn't going to be possible, they needed to pull in other people and allow a little bit more freedom and a wider net to begin with, even if they weren't able to control every piece of information that was coming in. That would have given us a better opportunity to solve the problem, like to sort of contain things. But even if we'd been able to contain it, like Australia was able to, or New Zealand was able to, because no country was really prepared enough to contain this disease, we were never going to be able to really contain it. So I think those were some missteps. I think the other big learning lesson that I've gotten is that politicization of public health and the polarization in our political system and the way that social media can be used by almost anyone who understands how to do social engineering to work either for good or for bad ends up causing more of a rift and less of what we need to move forward and be able to get people to work together. The only way to live with an infectious disease in our midst is to work together. It is literally something that we have to share. We cannot possibly do it each on our own. And the inability of us to be able to agree on one set of facts and the constant desire to manipulate individuals and sort of throw out the facts and or cherry pick the facts in order to create wedge issues is a big thing that I did not expect in the pandemic. I knew there were going to be a lot of challenges, but I did not expect that. I probably should have, but that's not what my training is in. So I didn't.
I suppose in previous pandemics, going back hundreds of years, there's always been scapegoats and name calling. So I guess we are seeing history repeat itself. And maybe that's part of what we should include in our medical curriculums going forward, is that social aspect. And maybe that's a lesson learned for
Yeah,
future.
Kirsten, I think the biggest thing that CDC can take away from this is that social science is science too. And that they've never really incorporated an understanding of the social science of behavior change and of, you know, how to influence people and how to get the message across in a way that's going to avoid that sort of trampling that can happen when people want to wedge it. And I think that needs to be part of what we do going forward in public health. I study behavior change in hand hygiene before that's my sort of research interest, and in healthcare workers. And so I had a little bit of the pieces of the skills that I needed in order to communicate effectively about things, but that isn't enough. We need real serious consideration of the social science when we make decisions about how to communicate, what to communicate, and how to talk about things.
That's a great point. So then I guess let's talk a bit about prevention. And I'd like to ask you to consider, the U.S. approach to prevention, both in terms of the spread of respiratory disease, but also prevention of the diseases that make these respiratory illnesses more fatal, including cardiovascular and metabolic disease and cancer. The fact that disabled people were so much more likely to die of COVID-19. So can you talk to me a bit about the U.S. approach to prevention? And are there any countries that, in particular for treating these underlying conditions, have done a better job at preventing mortality from respiratory disease than the U.S. has?
That is like the biggest question it's like the question of everything. The answer is apparently 42, according to that computer. But anyway, I don't think I can begin to answer it. So the reality is that our healthcare system is broken. The way we pay for healthcare, the way people get healthcare, it's not fair, equal, or appropriate. The people who are sickest and need the most care aren't the ones who get the most care. The people that need the most medication don't get the most medication. And that is a problem. When our resources don't match the needs, we're not able to efficiently and effectively provide the care that people need. And then we have to talk about the philosophy of how we go about helping people. And this gets back to that idea of social science, right? For decades, for hundreds of years, our public health system has largely done stuff in the background, sort of like, okay, why don't we have malaria in the United States? There used to be malaria in the southern part of the United States. There was a huge campaign to get rid of the mosquitoes that carry malaria and that carry yellow fever because of an outbreak that happened in Philadelphia. And what ended up happening is we got rid of those mosquitoes. But it wasn't because everybody on social media was talking about the mosquitoes. It was because public health was able to just get the funding that they needed to take care of the mosquito problem. They were able to work with the organizations they needed to in order to solve this mosquito problem. They got the people engaged, and most people didn't really worry about it. And that has been the method by which public health has gotten this stuff through. Why don't we have cholera? Because we pay for clean water. We don't accept having unclean water in the United States. So the way that we live with infectious diseases is by investing in infrastructure and policies and public health that help keep us from doing that. But now any investment in anything, including information about what causes cancer, what doesn't cause cancer, how to prevent heart disease, how to prevent this or that, is sort of all over the place. We have agencies and government, sort of non-governmental companies that are sort of telling the public what is and is not good for them, when it may be more in the interest of the company than it is in the interest of the public. But their voice is just as important as the voice coming from public health, and gets just as much play and just as much sort of focus and emphasis. And so we end up in a situation where people don't really, it's really hard to know what is the right thing to do. I mean, even as a physician, you realize how nothing is really that black and white, right? And so that can make it really complicated. But I have a pretty good idea about what is good for my health and what is not good for my health. And I can do a lot of stuff. It's allowed in the United States for me and encouraged for me to do stuff in the United States, and policies that support me doing things that are not good for my health in general. But we also have ways in which we have policies that really do support things that are good for people's health. But it seems like it's very spotty, right? When it comes to nutrition and access to food, it's clear which foods are better, what's a better way of cooking, what's a better way of providing nutrition to individuals, but then we make it easier to get and cheaper to buy foods that are less good for people. And we have marketing that makes it really, really positive for people. They feel positive when they choose those foods. And yet we don't allow people to smoke in restaurants in most places in the United States, or even outdoors at restaurants, because we know that that can be really dangerous to the people that are working there. And so in some ways we've made a lot of progress, and in other ways we haven't. I think that countries that look at health as a responsibility of the government and a sort of providing health care as something that they need to do for their citizens, something that is separate from the free market, because there's nothing free market about if you have meningitis, you need to get in to see somebody. There's no free market. You're not going to consider which hospital you go to. You know, you're not going to think about whether or not it's really worth it to get that LP, and should you pay for it out of pocket. You don't even know how much those things cost. So free market doesn't really have anything to do with healthcare, but we pretend like it does in the US. Outside of the US, people think in places that have better health coverage, there's this understanding that if we don't do things that are pro-health, we'll have to pay more to take care of people's health. And that's not good for our bottom line or for their bottom line or for how much we have to tax them. It's a shared responsibility. And when things are a shared responsibility, they're addressed in a little bit more of a deliberate way. In the United States, we don't really do that. And so I think some places have been more deliberate. That doesn't mean that they've been 100% successful. But when it comes to COVID, the United States is the only place where people have, revolt against masks because they are some sort of mind control device, or some sort of you don't hear people in Germany saying masking doesn't work. They may argue about when it's appropriate to have a mask mandate, or when you shouldn't have a mask mandate, or should little kids be required to wear them, even though they do pretty well with the infection. There are certainly arguments to have in those margins where the science is thinner and not as helpful. But there are also times when everybody acknowledges in many of these countries that masking is an essential part of preventing people from getting COVID, whether or not they're going to die from COVID today or need a heart transplant 10 years later. It's important, since we don't really know how many people are going to need that. We need to do what we can to prevent it. And it's not a big deal to ask people to mask. Here in the United States, we have many years where it was okay to ask people to do things. I mean, I don't think you could get stop signs passed right now in many municipalities. I think people would fight that they need to just be able to go, and that other people should stop if they want to stop. I think that would literally be the argument. But we all know that stop signs are essential to an orderly, functional road system. So I think we lost our way somewhere. I'm not sure where.
That's a great point. So you talked about economics. What has been the impact? And then I want to ask you to please consider the second order impact. I know that health spending went down when we were all staying at home.
Yeah.
As a physician, are you starting to see sort of second order impact of underdiagnosed and
Absolutely.
people? And in particular, could I ask you to talk about any specific conditions? I know mental health is one that's been talked about a lot, but are there other conditions where you're starting to see growing incidence or higher cost cases because there's been under treatment over the last few years?
Well, talking about mental health first, I actually think that mental health has gotten a big boost from the pandemic. I mean, yes, more people have mental health problems, but they've also had more access than ever before because of our ability to use remote conferencing to do a lot of mental health treatment and evaluation. And so while people have needed mental health more, we've been able to meet that need and exceed it in some cases and provide better mental health coverage and services to places that didn't have good coverage before. So I feel like mental health is maybe one of the success stories of the pandemic. On the other hand, I'm sorry, I know that people are unhappy about the mental health bad outcomes, and a lot of people have been affected by that because of the pandemic, but that's sort of, I hate to say it, but it's a big bad pandemic. I mean, if you have a big hurricane, people are going to have mental health issues after being completely displaced and having their entire lives upended. Same thing's true of a pandemic. When we talk about other things, though, there are a lot of second order consequences, and that is the most important thing. The short-term decrease in spending is nothing compared to the problems that we've created. I'm just getting a short laundry list here. During the pandemic itself, people couldn't get care for things. We certainly saw more people dying of things like heart attacks and strokes because they either A, were afraid to go to a hospital because they didn't think they could get care, or B, they came to a hospital and they had to wait too long to receive care because we were clogged up with COVID patients. Now, those two things are less likely to happen now than they were then because we've done a lot of good for decreasing the acute illness phase of COVID. But the other thing that we're seeing are, as you mentioned, lack of cancer screenings, people not being able to get timely, time-sensitive cancer surgeries because hospitals were unable to provide care for elective procedures. Elective procedures are not just nose jobs. Elective procedures are having your colon cancer removed. Anything that can be scheduled a day, a week, a month ahead of time is an elective procedure. So if you needed to have your melanoma removed from your skin, or your colon cancer removed, or a debulking surgery for your ovarian cancer, those were considered elective, and in some cases were put off for 6 months. Those patients died way earlier than they needed to because of that loss of surgical care, because we didn't have enough masks, gowns, gloves, medication, and staff to provide those things in the very early phase of the pandemic. And then in the second and third waves, didn't have enough beds for those people. That's a very real impact. There's a good chance that if you didn't die of COVID and you died during COVID, this whole dying of COVID versus dying with COVID, yeah, there's a lot of people who died because of COVID, not due to COVID or related to COVID. And that's a real problem. But I think one of the biggest things that we're going to be talking about in the next 5 to 10 years are the long-term consequences of millions of people getting 1, 2, 3 infections with a new infectious disease that affects more systems than just the lungs. The acute phase of illness that people are going through is just one piece of what we need to fix with COVID. We can't declare victory just because people are less likely to die right now. Our vaccines are wearing off. The variants are coming new. And so we could face new, fresh challenges from acute disease. But 10 to 15% of people who get COVID as a breakthrough infection after being vaccinated, even though they had mild to moderate COVID symptoms, no need for hospitalization or treatment, can end up with long COVID. And long COVID keeps people out of work, keeps people out of getting other medical care that they need. It keeps people from being able to take care of their families and to be able to provide for loved ones. And that is a real problem. We also know that there are additional organ damage that are not part of what I would traditionally consider long COVID. Things like heart disease that just shows up brand new after you've had COVID far more often than it would have shown up if you hadn't had COVID. Strokes, blood clots, and my least favorite of all, cognitive impairment. I think that when we look at all these children, there is good evidence now that there is some cognitive impairment after even mild infection in some individuals. We don't know why some people get it and some people do not get it, but we do know that even children can have this. This idea that it's totally fine for kids to get COVID because they'll be just fine afterwards is not something that I'm a fan of when we're looking at a bunch of children with MRI and sort of neurocognitive testing that shows that they've had declines after having had COVID. I'm not willing to take that risk for my child. But I think a lot of people don't know that. They want to see their kids playing, having fun, going to school, and they want to get back to work. And there isn't they don't have a lot of room in their psyche and their ability to sort of understand that there may be downstream effects of the decisions that we made today. And I don't think that our public health system is doing a really great job of sort of mitigating for that or allowing for that. But on the other hand, people really aren't interested in it. They're like, no, I'm not willing to do anything else for COVID now. I'm done. Thank you. And that I think is going to cause problems.
And then to that point, do you think there are different things that the CDC or other either federal or state bodies should be measuring then?
Yeah.
We measure infections, we measure hospitalizations. What should we be measuring in the future?
We should be measuring outcomes of individuals that die in the first 3 months after having a COVID infection and what they died of. And then we can do some math and figure out which things are really related to COVID and which are not. But that's a really deep dive, and people are doing that work. We just don't have all the answers yet. And so we don't know enough to be able to just stop doing any of our mitigations and say, oh, it's no big deal if you don't die from COVID right away, you won't. And I think the other thing we need to take a look at are we need more and more studies on long COVID, post-COVID complications, but those are going to take years to figure out. The one landmark study in Nature looked at the cardiovascular outcomes of individuals that had COVID early on in the pandemic, and they extrapolated using economic and mathematical modeling to look at what was going to happen in the future. And even including the effect of vaccines, which was overestimated in the paper, because they used earlier efficacy analysis than we have now, they suggest that COVID could become the biggest cardiovascular risk factor going forward into the future, bigger than smoking, bigger than cholesterol, bigger than body weight, bigger than any family history combined, which is terrifying if you've had COVID before. And it's adding to your overall long-term health burden that everyone carries with them. And I think that we haven't done a good enough analysis of whether or not we can carry that burden as a country. We realized we couldn't carry the burden of so many acutely ill people at the same time. But can we carry the burden of so many people, so many more people having heart failure earlier than they should have had by their genetics and other indications? I'm not sure that we know the answer, and I'm not sure that we are going to be able to do that. I think from a health economics type standpoint, I'm not a health economist, but from a health economics standpoint, we should really be looking at that. People are looking at it, but it takes a lot of time to get the answers to those questions, because it's going to take years to find out how many people are really going to end up in that situation. And by the time we get there, people are already going to be in that situation. And many more people are going to be doomed to that situation. Maybe it will be less severe. Maybe fewer people will be involved. But I think we all learned from the Omicron outbreak in the beginning of this year that a small percentage of a gigantic number is a lot of people. And so even if this is really very rare and unlikely to cause a problem for most individuals that have COVID, which is certainly going to be the truth, it's going to cause a lot of problems for families, for communities, for health systems, for insurers, and for our overall need as a country and our sort of economy and bottom line. And I think we have to include that in our analyses as much as we include how much people don't like to wear masks, which currently seems to be the main thing driving our mitigation plan.
Wonderful. Well, Dr. Linden, thank you so much. I'm going to ask you a final question, and I'm doing this both, saying it's the final question, both so you know, but also so people who are watching can start thinking about what they want to ask you. So my final question is really for the students who are nearing the end of their career and thinking about joining the professional workforce. As you think about the challenges and the opportunities facing us in the US and globally, what's your advice for students so that they can be prepared to be agents of change and help to really improve public health and health systems, be able to address patient needs, and also be financially sustainable going into the next generation?
You're the future. We cannot have people who are, that I'm not anti-boomer, okay? I want to be clear about this. I am not a boomer, I'm a Gen Xer. And I know there's there's a lot of this talk about going on right now. And I gotta say, I'm concerned about how old our politicians are and our leaders are. They did a lot of great and a lot of good in the times that came before now. And hopefully the people that are doing as much as they can now, people in my generation, are going to do our best, but we're not going to do as good a job as what you and your future people are going to do. You guys need to pave the way for what's new after this, what's coming after this. And there's a lot to be positive about. Every single pandemic that's happened in history, every epidemic has resulted in lots and lots of positive changes, especially in public health and in arts and sort of culture. So think about most of the advances that we have, like the clean water comes from the work that we have from the work of cholera in London in the 1800s. We learned from the Black Death about contact precautions, about keeping people isolated and separated from one another, which seems evil, but works really well when you don't have any other options. There's also major changes have happened in hospitals and in healthcare. You know, look back at all of the policies that changed because of different outbreaks. The number of people that can live in an apartment, or the number of units that you can put in a building, the number of bathrooms there need to be per unit, are all because of gastrointestinal disease and typhoid outbreaks that happened in the past. The safety things that we have in place in hospitals are because of outbreaks and problems that happened in the past. We're going to see major changes. What I think will come out of this, major improvements in ventilation standards across the world. And I think that's going to be so good. I also think that this is going to help us to get a better idea about what global equity really means when it comes to health. We can't ignore whole continents of people and assume that, well, they're just different than us. They're not. They're our family. They are our people too. And if they get horrible illnesses, it comes to us. And if we get horrible illnesses, we share it with them. We need to work together and raise the tide for every boat. And that's what you guys and the future are going to do. You have the chance to, as soon as when these older individuals that have, a different way of thinking, they have a sort of older way of thinking, when those voices grow more silent, there's room. And as we try to silence some of the more ridiculous ones, you all need to take that space up with voices that say, I hear, I understand, I see, and we can do this together. So my advice is to stay positive, but always to think about what your guiding principles are, what your values are. And if your values really are inclusion and participation by everyone, then really strive to include everyone. I think if we are really thinking about equity and about fairness, then really try to make it fair. And we have to work toward, I don't know what all the answers are, but I know that they are in the minds and in the creativities of the people that are here watching today. And so take your chance.